Welcome officially to the Advocacy Exchange. I am Dave Craig, the CEO of Grit Health, and Grit Health has the honor of bringing the Advocacy Exchange to life in partnership with Bristol Myers Squibb. All of this started right at the beginning of the COVID pandemic. And what has happened since that very quick and very urgent beginning is now that we've brought together more than 300 advocacy organizations and 31,000 community members from more than 90 countries around the world onto this 24/7 virtual platform. It is just amazing to know where we started, where we are today, and of course, most importantly, the change that we're all going to be a part of creating in the future. Each of us are the most important catalysts in creating the future of health and healthcare that we believe. And I would like today by acknowledging one of the Advocacy Exchange members who exactly that, dreaming big and living big. Jody Hutchison Sanford wanted to get a payer and somebody that had system bring a new perspective that we hadn't had yet. And how often do we have the chance to have a conversation with somebody like Mr. Mark Bertolini? Mark is a national healthcare thought leader and the former chairman and CEO of Aetna Inc. He is also, I'm learning, one of the most authentic and compassionate humans I have ever met. We're going to have a conversation with Mark where he'll share his personal and professional perspectives about healthcare for the next 10 to 15 minutes. And then we'll have a Q&A session before we move into our working groups for the session. It is with that, I have the deep honor of introducing you to Mr. Mark Bertolini. Welcome, Mark.
Thanks, David. Thanks for the very kind introduction. It's just like my mother wrote it. Up on my everybody can hear me? Yep. Good. My journey started in December of 2001 when my son was diagnosed with an incurable cancer, T-cell gamma delta lymphoma. Only 34 people had ever been diagnosed with it. All were dead. And they gave me 6 months and told me to take him home. He was 16 years old at the time. He was the youngest ever to be diagnosed with this disease. I, at that moment, quit my job and I took him on the road to find doctors who would give me insights. And the last place we went was in Boston at Boston Children's Hospital in the Jimmy Fund Clinic. And we met an amazing physician named David Guinan, who said, this disease had this really cool idea about an orphan disease, which I've never seen, but what if we did a bad bone marrow transplant, which will then create graft versus host disease, which will then destroy T cells, which are the cells that are cancerous in his body. It's going to be horrific because he's going to get sicker than he is now because he's going to get graft versus host disease. And if we can cure the graft versus host disease, he may live a full life. So I said to my son, you want to do this? And my son said, if you do it with me. So I literally moved into his hospital room with him and slept there with him every night in his laminar airflow room, all gowned up half the time. The only time I ever left was to go to the gym between 10 and 11 in the morning so that he could get his daily ablutions. But from 9 to 10, I met with the medical team every morning, and I had a Harrison's internal medicine text with sticky notes, and I had a laptop with PubMed on it, and the NIH website where I talked to the NIH team. I blogged with the NIH team and talked to them about my son's disease. A lot of crazy things happened to follow over the following year and a half. Eric was in the hospital for a year and a half. Today he's 35. He has 2 children. He's married and he's living a productive life. He's the only one to ever survive his disease. In order to do that, I had to abandon all hope about anything other than his life and spend time with him in his room, understanding his disease, making sure I understood the medications he was on, asked a lot of questions that a lot of doctors didn't like. I remember I had one doctor say to me, "I'm tired of answering questions to somebody who's not medically trained." And I asked him to step out of my office, out of the room, and he was by, and the patient bill of rights was right there on the wall, and I pushed his face up against the patient bill of rights with the back of the collar and said, "This is the patient bill of rights. My son's a minor, therefore I am the patient. And I have every right to know everything about my son's case. So you're no longer on my son's case. I don't want you on my son's case. You need to go somewhere else." And so began a journey where I took control of his case. There's a lot of story behind it that I won't go into, but what the conclusion I came to during the time frame was that he was in a system that wasn't a system. He was one of 13 kids on the floor who had the worst disease and probably wouldn't live. And by the way, of the 13, he was the only one who did, in the lymphoma unit at Boston Children's Hospital. And I came out of that learning a lot of things. One, that if he was going to go into hospice, I was going to have to admit he was going to die and give up all hope, which I refused to do. But when I went to Aetna, I built a program called Compassionate Care, where patients now can go into hospice early without having to give up curative care and without having to admit they're going to die in 6 months. It has changed people's lives. It has changed families as a result, and it has eliminated a lot of guinea pigs for the medical system, who always tried to respond to the family by doing one more thing to see if they could save mom, dad, brother, sister, son. The other thing that I did is I came away understanding how the system wasn't linked. I mean, he was allergic to certain foods. They kept showing up on his tray. There was no connection between the kitchen and his case file. The social issues around visitors and around his mental health were disconnected from his care. We actually introduced craniosacral therapy and Reiki during his treatment, which did huge things for him, and began to build my interest in complementary medicine, which I also took back to work. But probably the most important thing for me is that little things like making sure his lines didn't touch the floor, his IV pole, his lines, making sure the nurse had the medication for the right machine because he had 3 machines on him at all times, making sure his tray was without allergens, which would put him into anaphylaxis and cause him to have even more difficulties given the cure path that we were on, and his immunosuppression. Making sure that he had as much of a normal life as possible while he was there, even though he was in this laminar flow room in this floor. And so I became a very difficult parent. And even one of the things that I found most amazing is that Dr. Guinan, who was my partner in all this, when things would look bleakest, would call me and say, "Meet me at McDonald's for some fries and a Coke. I'm going to tell you what I would do if this was my child." And she kept me going. So I want to describe to you what I think a better system is, and the way it should work. A year after my son left the hospital to the day, broke my neck extreme skiing, and I've lost most of the use of my left arm. I was in a coma for a week. I have terrible neuropathy. I'm in constant pain. I don't use pain medication. And in that journey, I found myself when my neck healed, the medical system said, "You're done." And I never described myself as a spinal cord injury survivor, but that's what I am. I have a quadriplegic injury, but because I fell into a river and laid there for 2 hours, my spinal cord did not rupture. Otherwise, I would have been a quad. So I'm what they call a super quad. I'm a walking quadriplegic, and with a lot of pain. But I don't describe myself that way. I describe myself as somebody who has terrible neuropathy and wishes he could fly fish, play the piano, and golf like you used to beforehand. Even though I'm back on my road bike, back on my motorcycles, skiing again, all those sorts of things. I broke my neck skiing. I'm doing all those things. And I was able to run a major Fortune 50 company for a decade. All because I found ways to get my life back, which I had to find outside the medical system, which only offered me drugs. So imagine this world where you have someone, where you start the conversation in a completely different place. And this is the strategy behind the CVS Aetna merger, by the way. This is the deep, dark secret. And let's say you go to a place that is in your neighborhood and you have a conversation with somebody about what is it about your health that gets in the way of the life you want to lead. So if I'm a diabetic with pedal neuropathy and somebody says to me, what is it about your feet that impact the life you'd like to lead? And you say, well, I used to walk to the senior center, or I used to take the grandkids for a walk in the park, and I can't do that anymore. And you say, well, what if we get your diabetes under control and you can do that again? Now you have an engaged patient on a plan that works for them because it achieves an end for them. And then what if we build the system all around that, and that the insurance company is in the back of the place, not in the front? It's not about getting an ID card or insurance. It's about financing the care plan that we've come together and put together in a way that is the best for you, that will result in the best outcome. And we find the most affordable way to provide it, including if that includes complementary medicine or complementary care. That's the system we should have. That's the system that will result in more healthy people who are living lives to their fullest. Because as one, the head of Department of Public Health in Boston put it when we did or Baltimore put it for me and my team when we did a poverty simulation, the opposite of health is poverty. When you don't have your health, you can't work, you can't function, you can't support others. And shouldn't the healthcare system be an advocate for those seeking optimal health versus a system that keeps score of how much healthcare you've used? And so our world under CVS and Aetna is that CVS becomes think of it, a pop-up tent without walls in your local community, offering services that are relevant to that community in health and in services, and not just selling shrinking hoses and Reynolds aluminum foil, which is always too costly because they have to charge more to service it in their stores. And what if that place is a place where you can gather and meet people? You can work through social issues. You can get counseling, all those sorts of things at your doorstep, because there's a CVS store within 5 miles of 80% of Americans. And wouldn't that be a better place to go than to a healthcare system and wait in line, expose yourself to nosocomial illness, and have to fight for follow-up afterwards and figure it out on your own? How many people remember triptychs from AAA? So what if we built a triptych for your healthcare and said, here's your plan. Here's how it works. We're going to waive your copays. We're going to waive your deductibles. We've built your journey with you. This is the most cost-effective approach to solving your problem. And you can go into the system unburdened by administrative or financial restraints. I think that's the way the healthcare system should work. And I think that's a way that the healthcare system can be an advocate for better people, better economies, and better communities. So I can talk about any of that in any level of depth you want. I was born and raised in Detroit, in the city, so I can't be intimidated or insulted. So please, let's have a conversation about how I can help you be better advocates for the people that you help every day.
Mark, the first question we have to ask, I know for me, when I think of the CEO of a major corporation like Aetna leading an industry-changing integration like you did with CVS, I think of someone different than the man I see sitting in front of us. You're just so compassionate and so human and relatable. What was it like to have done all those things and be this type of person?
Well, I think this is the type of person that should run every corporation in America. We need authentic, compassionate leaders who can relate to the people they lead. And while at Aetna, I raised minimum wage from $12 to $16 an hour. I wiped out healthcare costs for 7,100 employees if they had, if they were under 300% of the federal poverty level, as long as they worked on their health. We had pet therapy in our buildings. The only time I ever said no was when they wanted to bring mini ponies for pet therapy. I said, that's not going to work. But we had dogs, cats, rabbits, and gerbils in our pet therapy program. We had the ability to donate to other employees, our PTO and our money through our foundation when they were in difficult times and needed help. We moved our employees out of harm's ways for hurricanes and disasters with their families and their pets so that they would be safe, instead of letting them fend for themselves in their own communities. And when you give an organization permission to take care of one another, to advocate for one another, you create a level of trust. And the only way you can get trust is if you give it. It's like love. You can only get love when you give it. And so this idea of building a trust-based model where the corporation views its employees as valuable as any customer or asset or machine that they have, you all of a sudden have a better company. And so I would say that I was uniquely prepared, given my journey with my son and with my own health, my accident, to lead a company when the healthcare system needed to change. I played the part to get the job, but when the job, when I got the job, I sat with the board and said, I'm going to still ski. I'm going to ride my motorcycles to work. I won't shave every day, and I'm not going to wear a tie. But I'll do a really good job running the company and leading the people. And they gave me that chance. So I think more and more corporations, and I think a lot of people working inside of companies are looking for people who are more empathetic and real and authentic and approachable. I always said to my board, if you could get away with undercover boss on TV, your board probably ought to fire you. And then one of my board members mentioned he was on undercover boss, and I sort of said, well, he had a great disguise. But anyway, other questions?
I love it. I see that Jen Sertle put a comment in the chat. Everybody, please feel free if you have a question or a comment to drop it in the chat, and I'll do my best to get through it as we chat. Mark, Jen's comment is something we talk about all the time in advocacy. When we're in these situations, many people don't have the background. Sometimes it's culturally not something that people are prepared to do. How do parents learn how to advocate the way that you did for your son?
I'll give you one simple answer. If your child was about to be run over by a car, would you push your child all the way and risk your own life? Yeah. So why wouldn't you do it in a situation like this? I mean, you're not risking your life by being assertive. You have a duty to be informed. And your organization is doing great things around that in building curated content for people to be able to understand how to understand. They have to answer your questions. They have to give you information. And so if you'd step in front of a car to save your own child's life, to pull them out of harm's way, at your risking your own life, this is a lot less dangerous by advocating for your child.
I love that. And by seeing others, Mark, it becomes possible, right? Like knowing how you fought for your son and for yourself, I feel like it's possible for me to do the same thing.
It is. And you know, I remember finding out about single patient compassionate use exception at the FDA for drugs that weren't approved by the FDA. It's 3 pages filled out by your doctors. They'll give you permission to use a drug that's experimental. I did it with Eric for 2 drugs. Gave him Premarin. He was bleeding out his body volume of blood every day because he had dysplasia from his graft versus host disease in his gut. And so I'm reading on the NIH website that kidney transplant ureter bleeding is stopped by Premarin, giving conjugated Premarin, 25 milligrams a day. So I went to the doctors and said, ureter, gut, kind of the same thing, not an organ transplant. Let's try 25 milligrams of Premarin. His bleeding stopped in 4 days.
I see, Betsy, hi. Your comment in the chat is so appropriate. We talk all the time about how advocacy can also put a burden on people, right? And how do we reduce burden on people going through these conditions? Mark, how do we, not knowing what questions to ask, learn how to be able to ask questions and learn what things we need to be asking about?
Well, I think it starts with curiosity. So when the nurse walked in the first time into Eric's room with 5 syringes in her pocket to put into 3 different IV lines, I said, "What are these drugs? Can you explain them to me? And why do they go in these machines versus the other machines?" And she described it to me. She took the time to describe it to me, so that then I knew that, here were the medications, because often they'd be in the middle of the night, they come with 5 syringes in their pocket. Are they going in the right IV line? These kind of mistakes get made all the time, and so I just curious, how does this work? Why does it work this way? Where can I find it in my Harrison's internal medicine text? And then I get on the NIH site and say, my son's got this disease, and there'd be doctors out there, and they tell me, I say, we're doing a mismatched bone marrow transplant to try and drive away. And they're going, "Well, this is a great idea, but you got GVH." And so they gave me ideas about how to handle GVH. So it's just a level of curiosity. I mean, if your child's being bullied at school, or your child's not learning, we all have incredible curiosity about how to help them, right? Well, this is the moment. I mean, if people say to me, "What was your most amazing accomplishment?" I saved my son's life. And I gave him my left kidney 2 years later when he needed it, which is usually raised on Bud Light. And I remind him that Bud is the appropriate alcohol to keep it tuned up.
He is a miracle, Mark, no doubt about it.
He's a miracle child. He really is. And by the way, spontaneously, his wife got pregnant, even though he was supposed to be sterile after the total body irradiation. So there's something this kid's meant to be. I don't know what it is, but he better do it right.
I'm positive he will. There's a comment in the chat, Mark, that, we believe in courageous conversations and saying things out loud, right? And, I think everybody in this meeting is an advocate or advocates for someone. And not all the time the things we advocate for are universally welcomed. And one of the questions was, so the merger between Aetna and CVS also had some perhaps negative perceptions about it. How do you balance, not everybody understanding or sometimes wanting to know more about what's behind the changes happening?
Well, I would like, I have a saying that I remind myself of all the time. It's, what other people think of me is none of my business. And what I need to do is I need to be present and of right mind and available for people to help people make better decisions. And the system's not working before the CVS Aetna merger, that's for sure. We're not getting care in the community and in the home where it belongs. Why not put insurance in the back room and out of sight where, it's not about the insurance product. It's about the quality of care and the ability to do as much in your community as you can. I had, ever since my spinal cord injury, I get every 2 years, I have to have some major surgery on my neck. And last year, I happened to have surgery and sprung a cerebral spinal fluid leak and ended up in the ICU at Mount Sinai Hospital in New York on March 14th. And was in the ICU for 11 days in the middle of the pandemic. I went into the hospital, the world was slowing down. I came out, there was nobody else. I signed out against medical advice on the 25th of March because I was sure I was going to get sick from COVID if I stayed in the hospital. And I went home, and when I got home, my wife said, standing in the back of the apartment, said at the door, "Take your clothes off and spray yourself with this stuff before you come in the house." And I needed a shower chair because I couldn't stand. The shower chair at the hospital was $252. I got the same one on Amazon for $38. delivered to my door.
Yeah.
So why should people pay a deductible on a $252 chair that's really only $38 if you buy it from Amazon? And you can put it through your credit card.
And the only way we learn is by connecting, right? By learning what others are doing. I love the comment that Betty just put in the chat. What are your thoughts about collaboration within the healthcare system now with EMR interoperability and patients having access to their data, and just how much technology is changing things?
So, it's an interesting problem. Right now, physicians do a lot of tests, and then you come in and they look at the test and they say, here's what I think is going on. When I broke my neck, I lost the use of my left arm. I had to have my shoulder fused. And I went to see a doctor at a very famous joint hospital that shall go unnamed. And he was the top shoulder guy in the country. And he walked in after having a staff examining and said, here's your permissions for an ablation of your spinal cord to get rid of the pain and to fuse your left shoulder. And I said, well, can we talk about my shoulder a bit? And he goes, oh, my team looked at it. I understand what's going on. I've seen the x-rays. I said, no, I'm not. I ride motorcycles and I need my arm in a certain position. He goes, you ride motorcycles? Are you crazy? And I said, pardon my French. I said, no, you're an asshole. And I walked out of his office. Because nobody's thinking about my life, right? Nobody's thinking about Mark, the functional human. They're thinking about the shoulder or the spinal cord. And so no matter what we have in the way of interoperability, technology, communication, unless we start with the patient first by saying, what is it about your health that gets in the way of the life you want to lead, you can't begin a conversation that's meaningful for that patient. Instead, they hold up a magazine that says, here's the cover of Men Fitness. This is what a healthy male looks like at the age of 35. Good luck. Really, they tell you nothing about how to do that. So, and my doctor, my primary care doctor, I called him Doctor, don't do that. He used to say, when I say, my shoulder hurts, he goes, don't do that then. But one time I got food poisoning and I had a heart palpitation. I went to him, I was drinking smart water because I knew I had electrolyte imbalance. I walked in, he sat down, looked at me, listened to my heart, says, wait a minute, comes back in with a 16-ounce bottle of Diet Coke, has me drink the Diet Coke. He listens to my heart, he goes, you're fine, let's do an EKG. Did an EKG, goes, go home. So wait, what happened here? He was trained in the UK. He said, we do good H&Ps in the UK. And what I know is you did have an electrolyte imbalance from a food poisoning, but it was a GI problem, which decreases bicarbonates. So the smart water you were drinking was for sweating, and you were actually making your electrolyte imbalance worse. The best source for bicarbonate depletion is either Perrier or Coke. You're still 20 pounds overweight, so I got you a Diet Coke. Go home. That's understanding the person. That's knowing the patient and having a robust conversation.
Yeah. So one of the last questions, Mark, and I think this ties together a lot of the comments I've been reading in the chat. So Brad Love on our team, who's with us here, has spent his career in public health and access to care. And Brad always reminds us how much the way we talk about things affect their outcomes, and the narratives that society use directly impact our ability to make change or not. So how do we as advocates and humans and professionals help move things from labels or words to having real conversations about change?
Yeah, there's a quote by Niccolo Machiavelli in The Prince. It's about how change is the most dangerous thing to occur, to make happen, because those that are favored by the old way of things fight very hard to maintain them, and those that are advantaged by the new won't believe it until they actually experience it. So that a change agent runs great danger in any situation. So you have to lead people along about what matters to them, not about what works, or what you think works, or what you think is the right answer. And so you have to engage people in a dialogue about, tell me about your health. And we did this with IDEO at Aetna the last year and a half I was there. I worked on defining what is the real value chain around health. And we found out that 42% of Americans have decided that the chronic diseases that exist in their family are going to kill them, and they're just waiting for it to happen. Dad had diabetes, died from it. I probably will too. Mom died of heart disease. Yeah, I probably will too. Little do they know it's really about lifestyle, nutrition, how you eat, all those sorts of things. And there are easy markers to follow and easy things to do to make a more robust life over time. But people have just given up. And so I think we've got to start with what matters to them, and engage them in that dialogue in a way that causes them to, sort of push forward on their own journey. And it's all a very personal journey for each of us.
Wow. Mark, we want to thank you so much for spending time with us and sharing your perspective us for the first time. Really want the future to be so. You are welcome here anytime, and we hope you'll come back and visit.
I will be more than happy to. Let me know when I can help. And I also do advocacy for patients. I get calls at all hours of the day now from parents who call and say, how did you save your son? And what should I do? And we have this conversation about advocacy every time. Don't take no for an answer. Watch the lines on the floor. Make sure the food tray is good, and make sure your child is well taken care of. And know more about the case than the doctors do. I know more about bone marrow transplantation than most physicians do. I wouldn't try it. I'm not going to practice, but I know about it, and I can ask tough questions. So,
I love it. Well, Mark, thank you for all of your individual miracles and your system miracles. Thank you.
Good luck for the rest of the day. Take care.
Thank you, sir. Thank you.
Ciao.
Ciao. Thank you, Mark. We are going to switch now to a 10-minute presentation, which will share with you how we got to the point that we're at today. So what are the things we've accomplished, and then what we're going to talk about in our working groups when we break into them in about 10 minutes. And these working groups are designed to create tangible change in the future. And that is only possible if we all work together and we all know what we're working towards. And so I'm going to share my screen. Depending on which view you're looking at, you may see me in gallery or you may see me in full screen. So please feel free to toggle in your upper right, depending on which view, if you want to see the presentation or an interpreter. So I am going to put this in screen view and share with you for just a few minutes cultural advocacy initiative of its kind in healthcare. And Pat Garcia Gonzalez was one of our first speakers last year. Her quote, I think, just embodies what we all believe. The things that we thought were not possible before are now becoming possible. And I think that just embodies what we're able to achieve when we come together. So we're just going to quickly walk through these parts so we can share with you the path we've taken and the future that we're building together. And so just to flash back to where this started a year and a half ago, it's almost hard to comprehend that in April of last year, about half of the world's population was in some form of lockdown, which impacted almost 4 billion people around the world. And although similar disease control measures like this have been used for hundreds of years, what we're facing is unprecedented. And not only that, we're not only facing it as individuals, we're facing it as community members and community leaders and change agents. And so if we think about the impacts to global healthcare that caused, it has interrupted, created problems, or altogether stopped or paused patient access to care, new medicines development, our global advocacy initiatives, and it really has been illuminating racial and ethnic health and healthcare disparities in profound ways in all kinds of areas. And BMS and Grit Health had partnered the year before COVID in 2019 to create a global virtual cancer conference. So BMS said, well, can we use that same platform to get this initiative up in weeks instead of months? And so that was our charter to act quickly. And so to do that, we launched this in a record 3 weeks. And our purpose, our mission for doing this was to create an innovative and bold online resource to elevate the awareness, engagement, and impact of advocacy efforts around the world and to support patients. And so all of this with more detail is on the site anytime for you to visit. And some of your comments really help us feel so proud of what this really means. These are just some of the survey responses and conversations we've had. You know, it's all about togetherness and collaboration to make this possible. I know that I feel like more is possible because of these connections now. And so in that spirit, the first advocacy organizations that started to build this with us a year and a half ago, there was 70 of them. We did 100 hours of live conversations with these groups to hear what you were dealing with. And that is what created all of these live sessions we've done so far. You can see them all on the right. 32 hours of with experts and thought leaders like Mark, patients, caregivers, peers, and we've really brought together a global community to be a part of these conversations. I adore that someone called this a Netflix for advocacy. These are all available 24/7 on the site anytime for you or your community. This presentation is also on the site now, so I won't read all the details. Please feel free to access it anytime, but our global reach and now impact is really starting to reach an impressive level because of this collaboration. And huge thanks to the Evoke Kind team for sharing this story and letting the word out and helping more people to be involved and feel included. So amazing stories. You can check these out online anytime that really share the spirit of the work that we're doing. And so as we evolve, we started with very tactical things like going virtual and best practices for virtual, and providing best practices for organizations and individuals. What we're discovering together is how much this is about humanity and how much we talk about the intersectionality of being human. We're not a cancer patient or a cardiovascular patient. We are a human dealing with something. And as Mark said, trying to understand our goals that we want to reach. And so that is why this platform has become an enduring community for the long term. And so it is our greatest hope that over the coming months, that in the collaboration that we're all doing together, we are creating a lasting coalition and platform that will create meaningful change. And when we go into our working groups in a few minutes, you will see for the first time, or you will get an update of the things that you have been a part of building. And so these are our 4 working group leaders. They have spent their individual careers moving each of these areas forward and moving people to feel inspired. And they are some of the most impressive advocates I've had the honor of working with. And so you'll get to choose in just a few moments which one of these working groups you want to be in. If you've been in one in the past, we would love for you to go back to that same group to get an update on progress. If this is your first time, please feel free to pick whichever group is most meaningful for you. And one of the things that Sheila said back in May of last year is that when a person first joins advocacy, we don't know the important history that led to this moment, nor the systems in place that prevent progress. We don't know all these things that came before us. And so our working groups are creating these tangible products to really help advance advocacy. This arc of advocacy to me is one of the most powerful things, because if you look at these historical moments over time, the end of school segregation, finally when homosexuality was declassified as a mental illness in 1973, Equality for Women in Credit Act, AIDS and HIV advocacy, just the earliest days of acknowledging health disparities, and finally inclusion mandated by Congress in NIH-sponsored trials. It is shocking to see how recent and sadly how little change has really happened, which is why we all have to be a part of creating change. Every time we share this, anybody on our team shares this graph, we learn new things about inequities that we didn't see or things that we didn't know are affecting health and healthcare. And so we encourage you to share this visual with others to continue inspiring conversations. So as we prepare to move into our working groups, what we are doing is creating a framework from advocacy perspectives so that to move this movement forward, each individual can learn from the past, can see a direction for progress, and can feel how important her or his voice is to creating that future in equality, in outcomes, in all of the areas we care so much about. And I will ask our working group leader, Gary, who's leading the Future of Advocacy, to give us an overview of this work product from that working group.
Thank you, Dave. So the topic of the working group that I've been facilitating with the various advocacy group members, and the work that we're doing that we're now starting to see cross-pollinate into other working groups, was around defining the future of advocacy. So what we have here on the slide is a framework of essentially standards and principles about how we can collectively shape the future of advocacy. And the group has worked very hard over the last 6 months to really define, firstly, what is advocacy in terms of what is important to each individual and their organization. And we came to an agreement with the groups that advocacy is what you define it, whether it's care, providing personalized or individualized care to a patient or their carer, whether it's empowering patients to advocate for themselves or empowering carers to advocate for their loved ones and patients, whether it is supporting access, ensuring that patients have access to the latest therapies, treatments, or care available to them in their healthcare system, whether it's awareness, supporting the great awareness of a therapy area, a disease, or even a new intervention for treatment, whether it's supporting research. Research is not necessarily an activity that all advocacy organizations or individuals advocate for, but some groups do champion research and funding for research. And then policy, making sure policy reflects the needs of the patient and the carers. And that's something very much that when we was listening to Mark's presentation, I felt that in one way or another, Mark played a very active role in the care of his son in each of these vertical pillars. And then beyond that, we then started to identify across these 6 pillars what is really important in terms of the standards and principles that we should try to encourage any advocate who is, whether they are 3 days into their advocacy career or 30 years into their advocacy career. And that is that everything we do around care, empowerment, access, awareness should be patient-centered. It should be holistic, treating the whole patient, not just the specific symptom. And once again, going back to Mark's story around the treatment of his shoulder, I think is a great example of treating the patient based on their specific personalized needs, not just the actual specific need of his shoulder. Comprehensive and individual. So making sure that everything we do, whether around care, empowerment, awareness, and research, it is going into the depths of the detail to ensure that it does work uniquely for that individual. And then lastly, I think one of the most important is evidence-based, ensuring that the work we do as advocates is grounded in evidence to ensure that what we are advocating does meet the needs of the patients. So this was a set of principles and standards that we created around the future of advocacy that we are now starting to see in the other working groups that will hopefully start to help inform some projects and activities for 2021 into 2022. Is that okay, Dave?
Wonderful. And Gary, it's really fantastic to see now how these themes are connecting across groups, right? So the things you guys have talked about as principles for the future of advocacy really tie beautifully to the things that Sheila and the Racial and Ethnic Health and Healthcare Disparities group are focusing on to create system level change. and with Neil in patient voice and patient-focused medicines development, really creating a framework from advocates to drive those things forward. So would you say that you see that, how these conversations are both the future of advocacy, but also cut across all of these areas we're focused on?
Most certainly. I think one of the nicest things we see when we recap at the end of each session as a group, there's always very common themes and trends that are happening. I think the patient voice we see in everything we do from Neil's group is how important the patient voice is. So there's consistently common ground, areas to collaborate, cross-pollination, even though we aren't necessarily merging our groups into one. There's common themes continuously.